So, namaste and good morning to everyone in this room. Um, I couldn't have imagined this 9 years back to have such an august gathering just for sarcoma. I feel very humbled that the senior most faculties from orthopedic surgery, from surgical oncology, from radiation oncology, from pathology and radiology, everyone are here. Thank you very much for taking time out. So while they prepare for the presentation, I had a tough time trying to get hold of everyone to, come together for this conference, and it's been a roller coaster ride for the past 6 months. I'll probably thank them again and again, especially Dr. Gulia, for initiating this. We were planning to do a smaller conference, but when Dr. Gulia said that he's more than happy to help us out, we agreed to sort of collaborate, and this is what we have. So, is it ready? Yes, ma'am. Just a little announcement. Dr. Sagar, who is the president-elect of IMSOS, which is the counterpart of MOSON in India, Indian Musculoskeletal Oncology Society, he will be a little late. Dr. Sudeep Shrestha also has some personal reasons. He's going to join us a bit later. So yesterday we were on time, and today we wish that we could also finish up on time so that the lunch is not delayed. Era taller emotion. What's ready? Go back. Back though. Yeah. So I didn't get much time to prepare this because whatever these things you are seeing, that's by me. So MOSON Story is basically a story of us. 2 teams, 1 team in Kathmandu, 1 team in Bharatpur. There are other surgeons who do a little bit of sarcoma, maybe a little bit of bone tumor, but these 2 are the high-volume centers, high-volume practice. I represent Team SARC, and Dr. Arun represents BPKMCH. So we'll just take you briefly to our world of sarcomas. It's a fascinating world for people who are interested in dealing with it. It's tough, but it's exciting as well. Otherwise, we wouldn't have spent our 9-10 years of our life just doing this. So just bear with me for the next 15 minutes. Now, you've been seeing this yellow ribbon everywhere. So the yellow ribbon is actually the emblem for sarcomas. Now, the problem with sarcomas are they're so rare, it's also called as the forgotten cancer, the other cancer. There's not much of interest from the, especially in context of Nepal, from the national health policy-wise, to do anything for sarcomas. So it became imperative to sort of have a society which had a formal a voice that we can raise to people who are in the higher authorities, so that patients who have sarcomas benefit from all the funds that they allocate to other diseases as well. So whenever you see a ribbon like that, that means that someone is trying to raise awareness about sarcoma. So you'll see that everywhere today. Now, one disclaimer that I have is, like I already said, that's how we felt as Team SARC, trying to uplift, other subspecialties. For this particular conference, we had to generate interest, saying that, this is what it is, and you should join because this is something difficult, and we need manpower, we need people to help us out. And luckily and fortunately, people listened to us, and the registration was, especially for pathology, it was filled up within 24 hours, and then slowly other subspecialty registrations also started to pour in. Now, what is sarcoma? I'm talking about sarcoma a little bit because this is a mixed crowd. There are people who don't understand what sarcoma is, especially our family members. They know that we get up early in the morning, then go to the OR, do something, and come back. Don't earn that much money, but we're already, prepped up and excited about it. So this is what we deal with. So sarcomas are rare cancers. They affecting the bone and soft tissue in our body. So in Nepali, we just call it harchuni, that's a mangsapesiko cancer. It's not a cancer that's spread there, but technically sarcoma means something arising from the bone and soft tissue itself. Now, like I said, it's rare cancer of the connective tissue, like bone, muscles, cartilage, etc. It's pretty rare. And what's different about this cancer is that it does not have any causal relationship with anything as such. And it mostly affects, unfortunately, school-going kids and young adults. Now, a lot of patients and anxious fathers and mothers, they ask us, is there anything that we did that caused the sarcoma? There's no definite answer to that as of now. Now, there are no definite data from Nepal as such. If you look at this registry from some time back, they talk about all sorts of cancers that we have in Nepal, but there's no mention of sarcoma as such. And in partly, this is our mistake as well, because we don't have a registry for sarcoma. And maybe with MOSON, we could have a more collaborative effort between different centers that are working in sarcoma care. So it's estimated that we probably have around maximum 1,500 to 2,000 cases, but not too sure about it. Unfortunately, many present after disease has spread, so there's nothing much we can do. Now, the referral system for sarcoma. So over the years, what we have found out is that the people who first see the sarcoma patients are usually the general surgeons, a GP, or orthopedic surgeons at the periphery. And so there's some sort of a patient holding at first, as in they would like to research about the case, read about the case, and see if they can do something about it. But nowadays, the thinking has changed a little bit. And that's for good, because they now understand that it needs specialized care. So we get a lot of referral nowadays, and which is good. Even before biopsy, we get referrals, and that has helped us to manage our patients better. And many patients also cross border to India for treatment, and we have had instances in which our colleagues in India have referred back the patient to us in the recent times, which is very encouraging, saying that they already have such a big patient load, and they understand that we have a good team here. So we've had referral back from Indian centers. So I recall Dr. Puri sending back 2 patients in the last 2 years, saying that, "Ab wapas chale jaan, wahi pe karwa lo ba." So that's a very good gesture. Thank you very much for that. And so we have to agree that there's still a lack of awareness about treatment within the community as well as with the medical personnel as well. And with the community, you can go in and do all those sarcoma awareness programs. But for the medical personnel, we have to go to their meetings. So one thing we have done in the recent past, was we went to the Surgical Society meeting and talked about sarcoma awareness. So it's that important, because soft tissue sarcoma especially is in no man's land. So sometimes in the gray zone. So sometimes the general surgeons would want to take it out. Sometimes the orthopedic surgeons want to take it out. So we always make it a point that we show our data. We show that these are the things that we're doing, and it's better if we do it. And so it's encouraging that we're also getting referrals from other allied surgical specialties. Now, like I already said, and I reiterated that cases are often misdiagnosed and mismanaged, but I'm optimistic that it's going to decrease over time, and it's actually decreasing over time. It's getting better nowadays. So there are many hospitals nowadays catering for sarcoma, but unfortunately it's restricted to Province 3, so we would like to expand. So we were actually looking at expanding beyond Kathmandu. Because we have a good team, we can do that. We're looking at far west and the east as well. So we are in talks with different centers if we can provide services there as well. Now this is from my group. So our cases have increased over time. It's not a big number as compared to high volume centers down south in India, but we do have a trend in increasing number of patients. We've also started getting patients from the northern belt of India as well. So the number of cases has definitely increased over the years. So interestingly, the first bone sarcoma patient that I got to treat after my fellowship was 1.5 years after I started doing sarcoma practice. All I received were soft tissue sarcomas, and it really took quite a long time before I got a referral. Now this is an important topic, and I'm very interested in this because this is a main barrier. So we were talking about endoprosthetic surgery yesterday, and the main barrier for getting the best treatment done for our patients is the economic barrier. There's no government funds, there's no NGO or INGO working towards it, and maybe it's our drawback as well. We probably should look around more. We're trying to find ways of cost cutting, so we have over the years have had collaboration with MRI centers who have been kind enough to do MRIs for even free, CT scans for free, and then even chemo. So we get a lot of sponsors who agree to do chemotherapy, sponsorship for chemotherapy cycles for free. But it's a very tedious task because the sarcoma surgery itself is difficult, and then there are logistic hassles that you have to deal with. So we go by the dogma that we're not leaving anyone behind. So whoever comes to us gets the treatment. And the problem with doing that is without a proper backup from the government, we are looking at individual people all the time, and it becomes very embarrassing when it becomes more than 10 patients or 20 patients. Even calling someone for the second or third patient in a month becomes a big problem. So we need a permanent solution for this, and I hope MOSON as a formal society will help in that. So the total amount of treatment for a typical case of osteosarcoma would be around 10,60,000 Nepalese rupees. But this is just at a government center. If it were in a private center, I would think it would be at least thrice as expensive. And there's no doctors or surgeons charged in this. So for the first 6-7 years, we didn't think about charging patients, but then that's not a viable solution. So we need to find a way to make sure that we encourage the youngsters to pick up this practice as something that is financially viable. Now we did a small study. This was me and Sonia a couple of years back. So we looked at this infamous 1 lakh fund that the government provides to our sarcoma patients. So we just looked at in terms of bone cancer patients, and what we found out was that there was only one patient left with some fund left in his account for surgery. Most of them finished it during the diagnosis, during the early neoadjuvant phase, during the late neoadjuvant phase. I break a bit. Dr. Sagar. So Dr. R.R. Sagar is the president-elect of Indian Musculoskeletal Oncology Society. He is our chief guest. You scared me. So this is what it is. The 1 lakh fund gets finished up just like that. And there's nothing left when the patient comes to you for surgery. And then you're asking them an uphill task of somehow finding a lump sum of around 11 lakh rupees. It's a very difficult task for them. Now coming to what is MOSON. So we thought about a couple of names. So like IMSOS, we thought of NEMSOS, which sounded very cheesy. So we stuck around with MOSON. It sounds like motion is life, life is motion, but it has other, funny, analogies as well. So let's not go into that. So it's a conglomerate of surgical oncology, medical oncology, radiation oncology, radiology, and pathology. Now, gathering them all together, it sounds very easy when I write it down. And in fact, I felt easy just writing these 5 names down. But trying to get everyone together was the biggest challenge of this conference. But luckily, everyone came at the very end. Now, why do we need MOSON? So we need it for recognition for the work that we do. We need it for the recognition of the patients who suffer from this rare cancer. We need it for awareness purpose, so that it's a common society in which Arun can work, in which I can work, my team can work, so that we can go around Nepal talking about sarcoma freely. We need it for advocacy, like I already said. We cannot do without funds. We cannot do without help from the government. It's a big amount for an average Nepali family to pay. And collaboration. So one example of collaboration is the recent collaboration we have made with the expert faculties from Tata Memorial, from faculties down south, from faculties from Punjab. So we are looking to collaborate more in the future, and I'm very positive that that's going to happen. It could be in terms of training medical personnel. It could be organizing annual conferences or CMEs together. And yesterday it was a house full it was very interesting. We learned a lot from you yesterday. Just a note, yesterday during the discussion, I was actually learning so many things after such a long time. So I'm very thankful to all of you who took time out to come here. And one other thing I realized yesterday was, when you're an expert, you can explain it even to a 10-year-old about what you're doing. So that was the feedback I got from my residents. Thanks. Now, awareness is important in sarcoma because, sarcomas, they are notorious for getting big within weeks and, even days. Now, with so many festivals in Nepal, there's Dasai, there's Tihar and everything. And Nepalis are in general very chilled out. They don't really much care about what's happening in their lives. So they would come to you with a small mass, then there's some festival, and they will wait for the festival to get over, they'll come back, then there's the rainy season, they will again wait. And by the time they come back, it's such a huge swelling. So this sort of awareness is important in our context, and that's exactly what we want to do in the future. So one thing we did this year, so we are very lazy otherwise, but this year we got out of our beds, and Krishna and I, Krishna around? Okay, yeah. So Krishna and I, we did this 50 kilometers cycling challenge. We nearly died, but we made it. And this was all for the sake of sarcoma. We enjoyed it, and we'll probably do it next year as well. So these are a couple of pictures from that day. It was scorching hot, but we managed to finish it. And this is Rishi looking smart. Where's Rishi? Okay. So we went for this television interview. It was extempore, and he did really well. So this is Roshini from AP1. I don't know whether she's here today. So she's made a couple of snippets that helped us out with talking about the sort of care that we are providing at different centers in Kathmandu. So what matters the most? So this is interesting. When I came back from the fellowship and I joined Bhaktapur Cancer Hospital, and I asked the chief sister in the OR, I asked her, show me the orthopedic instrument set, and this is what she showed me. So it was basically a set for amputation. Bhaktapur Cancer Hospital then was the place to go for amputation. And so we did a couple of amputations to start with, because we got them late. We got the patients late. But then we slowly built up our practice. But then nowadays we have cutting-edge technology, even in Nepal. So if you can believe it, this is an intraoperative CT suite that's present in National Trauma Center. Now, for some reason, we cannot use it as of now. We'll probably be able to use it by next year. We'll probably use it in our sarcoma cases as well. They use it for spine nowadays, I think. So we're waiting for software for sarcomas as well. But what I've realized is it's more than technology. Well, we need technology, but it's about people. It's about teamwork. It's about watching each other's back. So the early days didn't have many sarcoma patients, so we had a lot of time to take pictures. So this is my days in Bhaktapur Cancer Hospital. And they were very fond memories. Binayak joined in. Yeah, so Binayak is a childhood friend of mine. So like yesterday, we are yin and yang. I think he speaks. So we had ample time to, print the calcinium, even when there was a shortage. So these are all solar batteries that we used to print a calcinium, and even implanted it. Now looking back, I think that was a very not so good thing to do. Could have prepared ourselves better. And we had a lot of time to do, these flaps, because we didn't have a plastic surgeon back then. Nowadays, we have a lot of MCS plastics. So one way we spent our time back then was doing flaps for, PMMC tubular flaps, and then breast flaps, and abdominal wall reconstructions, and all sort of reconstructions. So that, in a way, sort of connected the dots. So nowadays, we don't need a plastic surgeon. We do our own flaps. And with Basanta joining in as a hand and microvascular surgeon, our expertise has gone by leaps and bounds. Now, talking about BPKMCH. So BPKMCH, frankly speaking, it is the biggest cancer hospital in Nepal. It's the Tata Memorial Center of Nepal. And that's where Arun Sikdel and Sushil works. Sushil, unfortunately, could not make it today. So they receive majority of cancer cases. They do a lot of endoprosthesis, biological and complex reconstruction. And I'm very happy that they have started their own clinical fellowship in orthopedic oncology. And Gopal, I think, is here. Yes, Gopal and Dipendra, right? Yes, so they are the clinical fellows from BPKMCH. Really proud of that. And these are a couple of pictures of Arun and Sushil from BPKMCH. And I'd like to personally thank Arun for taking time out and coming. Now, Team SARC is a bit dramebaz. So this is our Basanti. So this was while he was training at NUH in Singapore. So he did his clinical fellowship in hand and microsurgery from NUH. So the concept of Team SARC is a concept of additive skills. So we're not adding the same skills from everyone. We're looking at specific skills that we bring into table. So it's much easier to get job done. So the thing is, when we started, I thought I'd do everything on my own. The problem with that is you'll probably have a big name, but then the stress will kill you. So all have been trained at high volume centers, and we hop around a lot. So we actually have privilege to at least 8 out of 10 major hospitals around Kathmandu. And that's a big number. So we've been around to many, many hospitals, almost all hospitals in Kathmandu operated there. The reason for that is some hospitals are better for pelvic surgeries, some hospitals are better for vascular surgeries. Like the specialists are sort of scattered around, so we have to do that. So hopefully in the near future we'll have one big center where we can all do that. But as of now, we just have to hop around. So these are a couple of pictures of my team. So we do a lot of R&R after a couple of months. So we go around a lot of places. We have a lot of parties and a lot of junior consultants and fellows. They come in and go out from our group. Some want to join in for a couple of months. Some stick around for a year or so. It's not a formal fellowship as such, but there's a lot of learning that goes on there. And I'll take this podium to invite our junior orthopedic colleagues and friends who want to join us, who want to sort of know what orthopedic oncology is. They can come and join us. Now, when I say people matter, it's also about patients. There's a face behind that X-ray. There's a whole person behind, a personality behind those X-rays, and a lot of patients that we deal with are kids. So these are some of the kids that we dealt with Ewing's and osteosarcoma last year at KIST Medical College. Now, this is also a story of resilience. So this is a patient's father from the far west. Now, we usually have patients, parents complaining about how poor they are and how they have not been able to manage funds. But we do have patients, families who come to Kathmandu with nothing, and they sort of start these little petty businesses to make sure that they pay towards the children's treatment. So this is one of the patient's father. Now this is interesting. So Binayak is a very avid trekker. He's probably been throughout Nepal trekking. And this was completely out of the blue. He met this lady at 4,000. How high was the place? 4,400 meters. She was running this hotel. She's a patient of ours who had undergone a biological reconstruction. So it was amazing. And I asked Binayak to take a picture out in the snow, and that's exactly what he did not do. So we go around in conferences. So this is Rishi speaking up about sarcoma at our national conference. Then there's Binayak. So this year, we take pride in the fact that Rishi went to Korean Orthopedic Association with a paper on sarcoma. It was a wonderful opportunity for us to present our paper, but I guess it was not that interesting. But jokes apart, Rishi is like the heart of our group. So this is MOSON Gogadi. So when we were in Chitwan, so we had this good time with Arun and the bunch. So this is at Saura, and this is motion is what brings us together. And I'll probably thank you again at the end, but thank you very much once again to all our faculties. All these are big names in the field of sarcoma. Thank you very much for coming down. And thank you very much to my organizing committee, especially Dr. Abhimanyu Jha for being the pillar of foundation for sarcoma care, without the pathology reports, we could have done nothing. Thanks very much. And thanks to the wonderful organizing committee that I have, especially Ramila, Ranjana, and Sonia, and my amazing team, Sark, and Amrit too. So Amrit has been working quite a lot. Neeraj, I don't know whether he's here or not. Thanks a lot. We'll do the thanking part at the end. So can you guess who this is? This is a very tall guy who visited us back in 2018. So you can't see his upper torso. So this was actually Peter Ferguson and Jay, who visited in 2019. So they're very big names in field of orthopedic oncology. And I had a chance to train under them back in 2012. And it was a good time. We also had a panel discussion at that time, but I would give it to you, Dr. Gulia, it was not as lively as yesterday. So we hope to get them back. This is a cool picture that we took when we got stuck in the traffic jam while coming back from Pokhara. So we have plans for November 2023. It's not going to be as grand as this, but we'll do probably a small CME when you're there here. So. Yes, thanks, sir. So from all of us, thank you for your blessings. So there's no I in a team. All of us are important. What we do is more important. And for our family members, for us ourselves, when we come out of our rooms, come out of our bed and do those long surgeries without thinking of anything else, we usually come back to and look at this. What we do really matters. Thanks a lot.
Now